Hello Protrusive, I'm Jaz Galati and welcome to this group function where we answer one burning question. Today's burning question has been sent in by someone. It is regarding endodontics. Is single point obturation good enough? What I mean by that is you chemomechanically prepare your canal, and now when you come to the obturation stage, you just stick one of those fat master GP cones in there, potentially a matching size to a rotary file you just used, and then you just fill up the rest with the sealer. Is that good enough? See, I think this is what GDPs all over the world are doing. We're not doing warm vertical compaction. We can be doing cold lateral compaction as a whole, but a lot of times you stick the fat GP cone in and it fits well enough, and there's not enough space for cold lateral compaction. So is this technique of obturation up to the mark? So that's what I'm going to find out today from Ammar Al-Hourani, who's a specialist endodontist, and we're going to jump straight away. Just one thing to say is the splint course is now just under 2 weeks away. I'm looking to launch it March 12th. It's the first time I'm revealing this, so March 12th, it should be launching online. This splint course is 100% online. It's packed full of videos. Like my reservoir bridge course, I'm really proud of it. It's got loads of rave reviews, but it lacked video. So I took that several notches further with the splint course, and you're basically like watching me, like you're like over the shoulder kind of training while I'm adjusting splints, while I'm going through the diagnostic process. It very much teaches you the very basics of an anatomy as a GDP and building up to a diagnosis and how to choose which splint will help your patient the most. Sometimes we're looking to just use a protective splint, but also with that protective splint to protect your restorative work or prevent the patient from pathologically destroying their teeth, there's a bit of a decision-making tree as to which splint, why, and when, and what are the risks of certain splints. So I'm going to go through A to Z of that, including the delivery from a stabilization splint to AMSers, the whole lot in between. So I'm so excited to share that. If you're interested, why don't you download one of my flowcharts? I've got a free flowchart for you to download, which pretty much, even if you don't do the course, you're going to find it valuable because it's going to show you when I prescribe certain appliances. Now, just a disclaimer, I made a flowchart and really it's a guide, but you should be deviating away from guide. Any sort of guideline, you should always be happy to deviate away from a guideline because there's no such thing as a cookie cutter approach to occlusion. So just read it with caution. It's there just to help my students of the course get an idea as a generalization. And if you don't understand anything on that, it's because it's very much there to accompany the course. But feel free to download it. You can access that on www.protrusive.co.uk/flowchart. That's www.protrusive.co.uk/flowchart. You can download that straight away. So let's join Ammar Al-Hourani to answer the question, is single point obturation good enough? Hello everyone and welcome to this group function. Today we've got Ammar Al-Hourani. Okay, he's a specialist endodontist. He works 2 days a week teaching undergraduates in Plymouth. He's 3 days a week in private practice in London, and he's part of the Endo Guys. And this episode is where we answer one burning question. And the burning question today, thanks to Ammar's going to join us for this, is single point obturation. Okay, so I'm going to spend just 1 minute here. I'm also going to check to make sure that we definitely are live. I'm going to spend 1 minute, just set the scene about how this question came to be. And basically, when I was a student, we got taught endo in our endo clinics, and we first, we started with K files. Then we moved on to sort of hand pro taper actually in dental school, and then we moved on to rotary eventually, which was cool. But initially we started cold lateral compaction with the like ISO files and ISO GP points, and then eventually we got taught how to use the matching GP cones or the pro taper. And when it filled that canal so beautifully, I realized actually there's not much space in there for your cold lateral compaction. And then eventually what happens is that you accept some compromises in practice. You want to be quick. So eventually I had a GP cone with a lot of sealer around the edges, and if there was a bit of space, I try and jam in a little accessory point. So my first question, Ammar, is okay. So thanks for joining me, Ammar. First question is, as a GDP, let's forget about BioCeramic Sealers for a moment. As a GDP, is that acceptable? That scenario I just described.
Yeah, I mean, that's a scenario that's probably going all the way through the UK. I know I've got a lot of my own colleagues I work with that probably do the same thing with H+. I think let's take a step back. I think we just need to understand the fundamentals first about why we're doing what we're doing. Endodontics is relatively straightforward. It's really broken down to 3 parts. Get the necrotic tissue out, create a taper in the canal and wash it, and then obturate. So obturation is the very last thing. Opening up, remove the decay, remove the leaking restoration, and then, once you taper it, the cleaning part is the most important element of the whole project, okay? Now, why do we obturate? What's the point of obturation? Obturation really just fills up your space that you've created once you've cleaned and you're happy with everything. Now, we obturate. The reason why we obturate is a number of reasons. You want to fill up the dead space. You want to clog up the dental tubules from the bugs, and you want to seal them all off so you can suffocate them from nutrients. And then you want to stop any percolation of fluid back in from the apex or from the lateral canals. Okay. Now, if you use GP, we use GP and we use sealers for that traditionally, and we still do. Okay, nothing's really changed over the last 40, 50 years, really. Now, if you use GP on its own, the problem with it is if you used it as a warm vertical compaction technique, it will shrink by about 7%. And it doesn't really have a hermetic seal towards the dentine. So you're going to have a gap between the dentine and your GP. And that in itself forms a void. And that void creates areas in which bacteria hasn't been suffocated. You can't entomb that bacteria. And that's areas of biofilm that is going to regrow, spore, release their toxins, and they're going to then affect the outcome. Okay. So then you have to produce something like a sealer, okay, to prevent or close that gap. Now, the sealer does a few things for you. It's antimicrobial, it fills all the gaps, it entombs the bacteria as much as possible or goes into the dentine tubules, and it gets into the nooks and crannies that your GP can't get into. Okay, don't forget, you're preparing a circle within an ovoid, and all we're trying to do is disinfect the canal as best as possible and reduce the bugs as to a point in which your body then starts to clean things up. You're not going to sterilize the tooth, you're going to just disinfect it. Okay. Now, traditionally, the sealer that we use is TubuloSeal, or more recently, AH+. The problem with TubuloSeal, which is zinc oxide eugenol, the eugenol itself is quite an irritant. It goes through the apex. It's really uncomfortable. It sort of dissolves over time. It doesn't really have a good bond to your canals. And then if you want to put a post in there, you've got oil, and you can't really bond to it very, very well. The whole thing becomes an oily mess. Some people still use it. I've not used it for a very long time, probably since I was a GDP 5, 6, 7 years ago. AH+ came along, a nicer material, resin-based sealer. It's a bit thinner. It bonded a little bit better to the dentine, but it's still hydrophobic. It's a resin. It's antimicrobial, has got a nice high pH. The cytotoxicity was not as bad. Sorry, it's great on a radiograph, especially the new stuff. AH+ Jet. It's like it's like putting an IR core in a canal. And then but the problem with it again, if you used a warm vertical, if you use GP, the single cone, and AH+. AH+ itself as a resin shrinks by about 6.5%. So why am I talking about shrinkage? Why is shrinkage a big deal for me? Well, if you look at the Endodontist studies, which came out a few years back, she talked about voids. Voids is an issue for us because that's areas within the root canal system. Don't forget, we go back to the original position, which is you're creating a circle with your file within an ovoid canal. So you've got areas which are not being touched by your file. And that's areas, therefore, which only the irrigant can into, and then hopefully your sealing material. And if your sealing material is shrinking, then that's areas where you can then have repopulation of the microorganisms, bacteria. And these are voids where things can regrow again and cause failure in the future. So is single cone with those materials a good idea? I'll go to the next point, which is, I think personally, as the most important element with both of these things is the irrigation and your coronal seal. If you've got great...
Ammar, that's a given, okay? I'm going to take control of it because that's a given, okay? So we have to have a clean canal. I'm totally with you. But I want to really twist your arm here. I'm trying to really twist your arm and try and get the answer in terms of the GP cone, right? So basically, but here's the situation. You mentioned about warm vertical compaction, but most of the audience here, we're GDPs, right? We're using cold lateral compaction, okay? And a lot of time, whether you can get an accessory point and extra GP cones in, it depends on what kind of a canal you start out with, right? So that scenario where you can't get another accessory point in there, but the GP cone, let's say an F2, F3, the Pro Taper system, and you get an F3 matching cone and you stick it in there, there's not enough space to put an accessory cone in there, but you still see that it's not as snug as you want in the coronal portion. So that all the TubuSeal that you're using, whatever sealer, AH+, is all around, okay?
Correct.
What should we do in that scenario with cold lateral compaction? Or is that Pro Taper system it was never designed for cold lateral?
The new matching systems have obviously been designed for the single cone technique in the sense that you want to use it as a warm vertical compaction technique. Okay, so you're cutting it back, you're getting that really nice tug back at the last 5 millimeters where most file systems now are not a progressive taper, they're a variable taper. So the first 4 or 5 millimeters of the canal, the apical part of the file is really what the GP is fitting into. And then the rest of it should be technically warm vertical compacted. But we don't have these materials. These are very expensive materials. They're technique sensitive. You're going to put a lot of pressure on the root. So from that point of view, as long as you've got, in my opinion, a clean canal, dried well, you don't have any fluid going back in there because you've got inflammation or inflammatory exudate, and you've got a really good coronal seal, I think you should be absolutely fine. I think it would be okay.
Yes. Okay, I'm so glad you said that. I was actually really worried because when I did that, I felt guilty, I have to say.
No, it's not guilty, but you need to understand that there's still limitations from the sealer material. So the sealers haven't really truly been designed for this purpose. But as long as you've got a good coronal seal, if you've looked at Ray and Trope studies, if you've got a good coronal seal, even with a poor root canal treatment, it seemed to do fine. So maybe we're looking at the finer technicalities of things. And at the end of the day, let's be honest, we're always judging the outcome of a root canal treatment by the white line. And if the white line looks great, then we all assume everything's good on a two-dimensional X-ray. Don't forget, that's not from a three-dimensional point of view. So that's why I think the BioCeramic Sealers, in my opinion now, sort of take over. I think they are the future because...
So I want to come to the BioCeramic Sealers. I just want to say at this point, because we've got some people live right now. So I want to encourage at this stage that if anyone's got any questions, send them over. Because then... So Nicola, hi Nicola. Nicola's based in Italy. He's saying hello. He's talking about BioCeramic hydraulic sealers, which you're going to come on to now. So if anyone's got any questions, okay, you can send it here. We have had one question from Instagram already, which we're going to come on to at the end. So in the first half of this group function, which we're doing amazingly for timing, you're really good there. You really answered my question beautifully, Ammar. Thank you so much. I'm not just saying that because you've given me the wink right answer. But no, it makes you feel good that all those obturations I did where I thought, I don't have a warm vertical compaction system. I'm just cold lateral compacting and there isn't much space, so I'm relying a lot on my sealer. But you're right, as long as the disinfection was good and the coronal seal, the Ray and Trope studies, 1985, I think it was, classic studies, you'll probably know the date better than I will. But that's amazing. So now, with the BioCeramic Sealers, give us a flavor of what most endodontists you think are doing now with the BioCeramic Sealers and how, as GDPs, we can implement that for our more simple endos.
Okay, well, we need to understand the science of the BioCeramic Sealer. If you give you a few minutes just to discuss that with your colleagues. Some people don't really understand what we've not really gone into the technicalities of bioceramics. It's not something we've been taught. It's not new. It's been out since 2007. But bioceramic sealers are really derivatives of MTA. MTA was obviously discovered by Mahmoud Turabenjad quite a few years back. And we took some of the active materials from that. So the tricalcium silicate, dicalcium silicate, calcium phosphate. Okay, and they put that into a sealer. And the nice thing about that is that if you look at all the studies from with bioceramics, it showed that it was bioactive. So it was osteoconductive in a sense. It created healing, or it stimulated the bone to heal. It's a stable material. It doesn't shrink. It actually expands by 0.2%. So it expanded. So therefore, it was a stable material. It's hydrophilic. It actually bonds to dentine through alkaline etching. It's a high pH of about 12.8, an initial setting, which is highly antimicrobial, and it releases calcium hydroxide as a byproduct. So as a material, if you were to have asked me as a GDP many, many years ago, Ammar, create me a sealer that would do everything for you, this is the closest we have to a sealer that sort of overcame all the limitations of the past. Don't forget, what we were doing before, and the technique of obturation before, was our technique was sort of being guided by the sealer that we had because we had limitations to the sealer. Now that sealer is actually pretty good. And the GP really only does one thing for us. It's a vehicle to push that sealer to where we want it within the 0.2 millimeters. That is what we're aiming for. Because if we do that, then that means we have cleaned to 0.2 millimeters. And that apical third is where we have most of the ramifications, the lateral canals, where we have most bugs that are difficult to clean, especially with big lesions. With vital cases, you can get away with it. With a non-vital case, with a chronic apical periodontitis, you need to clean that area very, very well. So now I have a material that's really stable. It does everything I want. It stays where I want it to be. It sets nicely. But where's the problems with it? The problems with it is retreating it is going to be a nightmare, okay? Because it's attached well. Don't forget, we go back to the original thing. You've created a circle within an ovoid canal. That ovoid part on the sides, you're never going to really remove it 100%. And if you've not prepared it to the 0 to 2 millimeters, it's going to make my life extremely difficult trying to get patency. If you look at some of the studies, patency was very, very difficult to re-ascertain because this material is rock solid. You can't dissolve it. You can't wick it out. You can't use chloroform on it. You can't use anything on it. You have to literally either drill it out or it's going to stay there because it has high affinity to the dentin.
Ammar, that begs a really interesting question then. So we obviously know that a lot of endodontists I know are using BioCeramic Sealers with a warm vertical compaction system with GP, obviously, as the vehicle, as you say. You put it so nicely there. So that's great. So that's what endo guys are using. GDPs, what do you want us to use? Do you want us to use, imagine we've done everything to a high standard. We've used sodium hypochlorite, 3% heated and whatever. We can go into in that whether it's necessary or not. We've used EDTA 17%. We've done a good sort of chemomechanical cleaning. And then we come to obturation, and we may not have warm vertical compaction, but we got a BioCeramic sealer, and we can squirt inside or place inside a nicely fitting GP cone that's going to be snug in the apical few millimeters. Should we use the BioCeramic sealer, which may make it difficult for you if you're going to see it for retreatment in the future, or should we just stick to using the TB seals and the AH pluses because of that scenario that we just discussed?
Ultimately, at the center of all of this discussion is the patient. Okay, so the patient really needs to get the best outcome out of all of this. If you are sure that you have located all the canals, you've gained patency, which improves your outcome by doubling it, you've done a really good chemomechanical preparation, you've really cleaned that tooth well, you've done an EDTA rinse to remove the smear layer, and you're happy with your working length PA, and you know you're within 0 to 2 millimeters, then go ahead and put your BioCeramic in there. I have no problem with that because it's not going to be difficult for me. That GP is going to act as a quasi glide path. I'm going to get back in there and be able to get to the apical 2 millimeters. And the apical 2 millimeters is the most important element for me because that's what I need to clean that area very, very well. So if you have achieved all of these areas and you've ticked all those boxes, then by all means, go ahead and use BioCeramic sealer. It's as simple as that. But if you
That's
think
correct,
you haven't,
if you meet all those objectives, you're probably not going to get to see it because it's probably going to be a success.
it's going to be a success. It's going to be great. It's going to look great on an X-ray. It's technique. The technique sensitivity is nothing. It's easy to learn. It looks great on a PA. You're going to fist pump your nurse in the end of it. You're going to look like you're going to feel like a hero. And so why not use it if it's there and it's going to do a great job and we know the science is really good behind it? Use it. But if you don't get to those points, then please don't, because that's when it's going to be very difficult for someone like myself or a dentist special interest or even other dentists to retreat that. And therefore, that might be pushing us towards surgery straight away rather than a retreat. And that's, that makes it more difficult then. You've sort of, for any root canal treatment, we need to remember one thing. If you do any treatment in dentistry, you need to always think about what am I going to do when it fails, not when it's going great. Always think about failure. What do I do next? If you think about it this way, it makes things a little bit easier to plan. And us endodontists are like that. We do the endo, but then I'm always thinking, if this fails, what am I going to do next? Am I going to do surgery or am I going to get back to do what I'm going to do? So I use BioCeramic sealers, but actually, Jazz, you're going to be surprised by this. Not all endodontists use BioCeramic sealers. I would say it's still a 50-50 mix. Okay, I like it because I like the science. I like what it does. It makes me feel, and I'm a little bit lazy, so I like it. Whereas others like to make their life, they want to use the H+, that's what they've been trained with. They like warm vertical compaction. They like it, how it looks in a PA. They like the skill set involved with it. Different people like different things. But for me, it just works. It works in my hands and I'm getting really good outcomes. And that lesion that I've got is disappearing or getting smaller over time. So for me, it works. But will it work in the long run? We just need to wait also for the long-term studies as well. We're still having to wait.
Well, I really like those answers. And I think you summed it up very nicely as a closing summary of this segment, if you like, is that as a GDP, now this is as a GDP perspective based on what I've just learned from you. If everything's going well, use the BioCeramic sealer, use GP, give your nurse the fist bump, as you said. But if you have any doubts that the root canal, which you're approaching from the best intentions, and maybe you just feel that one or two elements are not you haven't got patency, but it's not bad enough that you want to refer it or you need to refer it because now you're invested into that root canal, right? Maybe in that scenario you should be using the TubiSeal or the AH Plus or whatever to make a potential retreatment easier. Do you think that's a fair way to put it?
Yeah, fair analysis. Because even then, don't forget the coronal part. We're going to, most dentists are going to probably flare with the gate splitting, so it's going to be overly flared a little bit. So you're going to have enough space to still put a few accessory cones and give yourself some good lateral compaction. So I think it's fair to say, yeah, if you think you've cleaned it very well, but you just can't get to don't forget, patency is still one of those things. It's a debatable concept. Some people think, some scholars believe in it and some scholars still don't, some of the big scholars still don't push for it, So as long as you're
but
within 0 to 2 millimeters.
But we all have that gut feeling, Ammar, right? At GDPs, we all have that gut feeling that, okay,
Correct.
We know that this is going to be going well. So I think I like it. Let's leave it at that gut feeling and then base your sealer on that. Correct. But then let's not get into the fact that BioCeramic sealers are expensive. So it's there, use it, that kind of stuff. But I think you've covered it really well, Ammar, about is single point obturation acceptable? So I think you've done this group function justice. So in the latter bit now, We're going to take some questions because I have got some questions. So we'll take that
Can I
one
just
from
add one last
Instagram
thing?
right. Yep, go on. Please go for it.
One last thing. What I'm trying to say is that the obturation part is just one element of the whole thing. If everything's been done well, it's just one element. You can't put down your whole success or survival of a tooth or things going well on the obturation. It's all about everything else fitting together. So there's a lot of elements, and you can't ever do a study to say it's definitely the obturation system or the sealer is what caused the whole thing to work. So if you've got a dirty canal and a poor coronal seal, no matter what you're going to put in there, it's just not going to work. It's eventually going to come and blow up. You don't put rubber down, you've got saliva leaking in there, it's not going to work. And it's just common sense. As long as you've done a really good job, if you obturate it relatively well, you should get a good outcome. Your body really heals very, very well. The healing potential of the body is phenomenal. And you've seen a lot of terrible root canal treatments, I'm sure, that are still surviving 10, 15 years down the line, if not longer. So it just shows you that as long as we reduce, the bottom line is reduce enough bacteria in that canal and tilt the balance towards your body, and your body will clean everything up, hopefully. Okay.
Ammar, has anyone ever told you that as you get more passionate, you become more Scottish? I just thought I'd let you know in case anyone hasn't told you that.
Possibly.
So Gian, thanks so much for tuning in, buddy. He's asking, can I ask about restoration of the pulp chamber? Is it better to place GIC barrier, or can we directly etch and bond over the orifice before placing a composite core? And then the second part of that question, Ammar, is who should place the core restoration, the GDP or the endodontist? So the first part was restoring on the pulp chamber over your GIC barrier versus composite. And then the second one was who should be doing the core.
Okay, so first question. I think the most important thing is that you need to cut back the GP to the CEJ. Don't leave it hanging in the pulp chamber, because if your coronal seal starts to leak, that's going to leak very, very quickly. So make sure that at least you've cut it to the CEJ, okay? First and foremost. Secondly, two schools of thought really here. Some people like the GIC because there's been some leakage studies that showed that if the filling came out, it gave you about 30 days worth of protection against saliva. Others, are saying put the composite straight away. The likelihood, if you've got a really nice MOD or MO or occlusal restoration, the likelihood of that composite popping off just in one piece and just leaving the GIC is highly unlikely. Okay, so I think if you can cut the GP to the CEJ, get your clean the pulp chamber really well, make sure it's nice and clean, etch it and bond it, should be absolutely fine. That's not a problem. You don't have to have the GIC. I like putting GIC because I've read the books and I just feel happier and more warmer inside me that I've done a better job. But am I doing a better job? I don't know. That's the reality. I'm probably costing the principal more money. Second question, you were saying about who does the core. I personally think if the patient's already in the chair, they've taken time off, just get put the core in there. I've got the rubber dam on. How long's going to put, I use SDR or bulk fill. It's going to take me how long? 10 minutes, maybe 5 minutes. It's saving the patient another appointment, another journey, more time off. And then I think the dentist's going to be a bit annoyed if I put GIC in there. Drilling out GIC is a bloody nightmare. You know that as more than anyone else. So why not just leave us do everything for you, and then you take the glory shot, get the crown on there. It looks all nice. People remember you for having a nice crown, and that's it. Just so make your life easy, make our life easy.
I 100% agree with you on both counts, with the composite and with the fact that whoever does the root canal, just do the core at the same time and with good bonding protocols. Two more questions now. One is my question, actually, which is, what's your secret to getting a lovely, clean-looking sort of pulp chamber? So once you've done your obturation, quite often I look at it and it's a mess. You see these 3 orange heads, and then you see all this like white sealer mess and debris and stuff like that. So I do aerobraid and then try and clean it, but it never looks as good as you endo guys. It's almost glistening and shiny, like as if you guys have got like baby oil on it. Like, what do you guys use?
So first thing, I use an LN burr just to really clean, literally cut the GP point to the CEJ. Secondly, if I'm using H+, I use alcohol, rub alcohol, ethanol. Isopropyl alcohol will dissolve the whole thing out. That gives you a really nice clean surface. Not percentage. You could just buy it from QED. I don't know what percentage it is. Isopropyl alcohol. Alcohol's alcohol, probably 100% or 70%. That'll dissolve everything out. Ultrasonic tip is really good. Just the Cavitron on your 3-in-1. Just use that. Just give it a really good rinse and a clean, and then just that acid etch, really, really brush your bond onto the canals, and on the floor, on the walls. Brushing is the most important bit, not just a little bit of a dot here and there and everywhere. Literally brush it till it's glistening. Then, like Cura, it glistens, it shines back at you, and then everything's well, and then that's when you go for it. There's
And
no
with the
secret to
bond,
it.
it's so good you said that, because with the bond you get a better wettability for your actual resin that goes on as well. So that's wonderful.
Correct.
Next question from Mohammed Adam is solubility of bioceramics question mark. Do they meet the ISO standards? I hadn't even thought about that, but there we are. Is there a question mark over the solubility of bioceramics? Do they meet the ISO standards?
The BioCeramic sealers are not as soluble as, say, zinc oxide eugenol. They're actually very, very stable, and they set in moisture. So they're not, that's why the more drier the canal is, in fact, the irony is it takes much longer for it to actually set. So solubility, no, it's a stable material. It actually expands a little bit. So it's actually pretty stable as a material. It won't just, the ones that are very soluble, like I said, zinc oxide and the calcium hydroxide based sealers, those ones will dissolve freely. These are the ones you should be worried about. But this one, no,
Brilliant.
it's stable material.
Fine. We're going to take two more questions before the end of this group function. So the next one is from Jag. Hi, Jag. Hope you're doing well, buddy. He says, okay, we got one more from Gianmarco. I hate letting him down. He always has good questions. Anyway, Jagdeep says, bioceramic sealers for open apex cases versus your traditional MTA plug. Any opinion on that?
I think it's really difficult to manipulate a GP to an open apex. So it's just a lot easier to use something like MTA or bidentine. I find bidentine to be an exceptionally brilliant material for it. Compared to the other materials out there, it's actually quite inexpensive. So using that as a barrier is much, much easier to do, and it's much more predictable to do. And plus, don't forget that down the line, that patient's endo fails. You've pretty much done the retro prep. You just do the surgery and just shave off a little. You don't even have to shave anything off. You just have to clean it all off, and you've already got the retro prep ready. So with an open apex, it's just a lot easier to do it that way. Manipulating GP, by the time you put that in and down pack it, you might push some through. It just isn't the same. So yeah,
so traditional MTA is the way to go.
Correct. MTA or bioceramic putty you can buy, or bidentine. These are, I think, the way to go.
Brilliant. I'm going to ask one from, we've got quite a few now, so quick fire round questions for the last 6 minutes. Riba Hajo, or maybe Hayo, I don't know, I hope it's Hayo because it sounds cooler. For a young patient, 17 years old, irreversible pulpitis, doesn't say which tooth, with apex fully formed. Is there any special risk for GDPs taken into account, or shall I refer to an endo specialist? So I don't understand that. Maybe you understand it better. 17-year-old patients, irreversible, okay.
I mean, if they've got irreversible pulpitis, you've got two options here. If you think you can open it, clean it, and do a pulpotomy, and use something like biodentine and basically a vital pulp therapy case. Yeah, if you've got the protocol, but you need the magnification to know whether or not you truly have, the pulp stumps are actually not bleeding, because you don't really know. One could bleed, one could be vital, one could be non-vital. So yeah, with that, if you want to save the tooth or do pulp, vital pulp therapy, send it to a specialist. If it's a relatively straightforward root canal treatment, I think you should give it a pretty good go, because you also need to learn, right? So you need to learn somehow.
Good man, allowing the GDPs to have some cases as well. Thank you. Next question is from Shanil Patel. Shanil says, what's your method of
Shannon
sealer
Patel,
placement?
I hope. Jeez, Shannon Patel. I thought you
No,
said Shannon
not
Patel.
Shannon, not Shannon Patel. If it was
Patel.
Shannon Patel, he's definitely trolling you. No, it's not Shannon Patel. I know Shannon. What's your method of sealer placement? Put it on the GP or squirt it in first and then place the cone?
Is that for bioceramic or is that for AH+? It's a very different technique.
Why don't you answer for both? Okay, so let's go for AH plus and then for bioceramic if it's different.
Okay, AH+, I usually will put a little bit over the orifice and just a little bit at the very tip of the GP point, and I'll just put it in slowly. Okay, not quickly, slowly to the working length, and that should be pretty much all you need. You don't need that much. Don't put too much, because then AH+ is quite runny. You'll just get a massive sealer puff, and it's quite uncomfortable for the first 8 to 10 hours. It's all bioceramic, all sealers, bioceramic or otherwise, are cytotoxic at the beginning. Okay, some less so than others. So bioceramic, not as much as the AH+ or zinc oxide eugenol. So yeah, not a lot. You just need a little bit. Not a lot. You should be fine. And if you use the AH+ jet, you don't need any at all. It just literally lights up on your PA. Bioceramic is a little bit different. I usually will fill up the first third, so the coronal third, and then I'll unscrew the top and I'll put the GP point into that, and then I'll put it into the canal, and that gives me a little bit more control of the bioceramic. Okay, and I'll use less material. Okay,
that's also very important, economical. Let's see. Wajiha wants you to repeat the name of the burr you use for the removal of GP.
Well, you can get a few. It's called the LN burr, or you can get the Comet Endo burr. Just call the Comet rep. They know which one it is. It comes in either 29 millimeters or 31 millimeters. These burrs can be reused over and over again because they're tungsten carbide, and they're great because you can actually physically see what you're doing, and they come in different diameters, so it makes it much, much easier to look at. They're about £150. They're not very expensive.
I mean, I'll tell you what I do, Ammar, and most of the time this is successful, but tell me what you think of this technique. I get a gooseneck fat rosehead burr, right? So a gooseneck being extra long in the neck of it, so it can reach down to the apex, and I just put it on really high rev, no water, and I'm just, melt stroke a blade or cut away the GP exactly what I want. Is that a slightly risky method?
It should be fine, but just what the only worry is you could be stripping away a lot of the pericervical dentine. That's the few millimeters above the CEJ and a couple of millimeters below. And that we know from new studies now coming through for the last maybe few years, you remove a lot of that dentine, and then that's the dentine that you can never really replace, and that really weakens a multi-rooted tooth. Okay, and no material can replace the strength of that area. So, if you want, use something like an Allen burr, or use a smaller head and do the same thing, not a big fat head, something a bit in the middle. Like maybe a size 120 should do the trick.
I mean, if anyone's going to be doing this, tomorrow morning, just make sure you got, you should do anyway, but make sure you got decent tug back on your GP, and it's not like just, otherwise they'll just fly at your face.
Yeah, you got.
Don't ask me how I know that one. Okay, so last question, which we haven't addressed yet, which was from the Instagram, which is, what do you do? And it's such a common scenario, Ammar, right? We prep to, let's say, F2, F3 Pro Taper, other brands are available, and you get your GP cone, but it's, your file has been there, your F2, F3 file has been there to the apex, to the working length, but your GP cone is just not going, it's a couple of millimeters shy. What should you do?
Sure. So a couple of things. We need to, let's just give you a quick science lesson, very quick one, 30 seconds. All files that we use now are a bit more martensitic than they are austenitic. What does that mean? They're a softer file, they bend. They're not straight and raw, like rigid as before. So what that means is that the file itself will create that shape of an F2 or a Wave 1 primary, but it doesn't create it 100% because it's a softer file, okay? And your GP point will always have a little bit of discrepancy as well, okay? So it doesn't fit 100%. So you might have an 07 taper at 2506 or 2507, but it's not 100% 2506, not 100% 2507, okay? So to correct this problem, two things. One, you might have the older style GP where it's fitting at the top, so it's a bit fat at the top, thin at the bottom, so it's basically wedging itself at the top. So that's coronal tug back, okay? So check for that. Buy the newer GP points. That's tops you have in that, okay? Second thing is you might have a lot of smear layer in there and dentine shavings and debris, so you might need to wash that out. So activate the irrigant or GP pump, which is really cheap, and just liberate all that gunk that's in there. Get some EDTA, it removes the smear layer, dissolves the dentine, and that might be stopping it. It's a bit like Turkish coffee. I don't know if anyone's had Greek or Turkish coffee. Coffee's at the bottom, the bit at the top that you drink, and that is your dentine's that bit at the bottom, that mud. You need to get rid of that, okay? So that's the second point.
I love that.
Third point is your GP point is sometimes not fitting bang on because it's just not been designed 100% perfectly. So if you're using an 06 taper, buy 04 taper GPs. And that stops you. That means you've got good apical tug back, and it's not tugging back on the actual taper, okay, on the sides. It's tugging back only at the apex. And therefore, it really fits beautifully at the very, very tip. You will not get that problem. So go a taper shorter, not a size shorter, a taper shorter. So if it's 04, 06, buy some 04 tapers. You can get that from any shop, any distributor in the UK will get you that. And they're not that very expensive. And
amazing. Really, I love that analogy of the Turkish coffee. Actually, that was genius. I love that very much. We've come to the end of the episode. Just tell us a little bit about how we can learn more from you. I really like your sort of style today. I like your down to earth style, and I just love the fact that you actually, I think you understand us as GDPs. Obviously, you got the endo guys, but tell us a little bit about, because I sort of did your intro for you. I'd like to know, for those listening, a little bit about yourself and what you get up to, and how can we learn more from you.
So basically, I really didn't enjoy endo as an undergrad. I absolutely hated it. I actually had to go and supervise or shadow an endodontist to actually understand the principles. And from that point on, I've always thought, I never understood it. Maybe I was just a bit thick. I don't know. Maybe other people understood it better than me. But the long and short of it is I never wanted anyone to feel like that again. I wanted people to get, education, which is relatively cheapish. I don't want people to pay over the odds for courses. I wanted to be accessible for everyone. And me and my friend always had that dream that, we wanted everyone to be able to have, if they want education, they should be able to afford it. I came out with horrendous amounts of debts like everyone else, which I had to pay back. So the endo guys really is a simple concept. We show you our cases. We tell you what went well, what didn't go well, learning points. We've also got the Endo Guys Academy that we do with Colteen. Again, it's, we do it for relatively cheap fees, £250 to £295 a course. And we go through a protocol. So we do access cavities, canal location, and one principle on how to get a good coronal, middle, and apical prep with glide path files. And we just want to show you how you do it well, so that in practice you could use any file system you want, and as long as you understand the principle, you should use anything, and anything should potentially work. Okay, and that's what we've wanted to do, and that's what the Endo Guy stands for. Being there for everyone, being accessible for everyone, and being, if you want to text us, phone us, email us, whatever, we'll always get back to you. Because we felt the pain that you guys have gone through. We never understood it till I became a specialist, and even till now, I'm sometimes going to work and I'm like, it's damage limitation. I still make mistakes. It's just a matter of, I make maybe less mistakes, or I pick the right winners. I don't take every case on. I'm comfortable to say no. Once you learn how to say no, or this tooth is goosed, then things become a little bit more liberating. And maybe that just comes with experience more than just training, and that's what the Endo Guys is all about. They're for everyone, basically.
I really appreciate that. What's your Instagram handle?
It's just called the Endo Guys. Really easy. It's just type that up and you'll find it.
You can follow the Endo Guys. Ammar, thanks so much for covering that really well. Honestly, I always worry about doing these short episodes because the answer is usually, to any of these complex questions, the answer is usually it depends, right? And I'm so glad you didn't say those two words together. You never said once, it depends. So thank you for not saying it depends. But one last thing, because Daz has just asked a really quick, cheeky question. Daz says, for the Ellen Burr, slow handpiece or endomotor? Slow handpiece or endomotor for the Ellen Burr?
Slow handpiece,
Fine.
and use the middle. Always start with the middle, because it's the middle of the size. It's not too big, not too small. If you find it's too small, go one big. If it's too big, go one small. Simple as that. Keep it simple. Okay?
Amazing. Ammar, thank you so much for coming on the show today. Sir. It'll be on the proper podcast very soon, and it was an absolute pleasure. Thanks so much.
No, my pleasure. Thanks so much for inviting me.